This is ReachMD, and I'm Dr. Matt Birnholz. I'm joined today by Dr. Vincenzo Berghella. He's president of the Society of Maternal Fetal Medicine and professor of OBGYN at Thomas Jefferson University School of Medicine. Dr. Berghella, welcome to the program.
It's a pleasure to be here. Thank you.
So why don't we start right up with some updates from your perspective as president of SFM. Tell us a little bit about what's going on.
Yeah, the Society for Maternal Fetal Medicine has been around for 40 years, but we just went through branding initiatives. And I think the public should know that we define ourselves as experts in high-risk pregnancy, anything that is wrong with the mother or is wrong with the baby. And what we would like people to know is that we would love to share our knowledge and expertise in both clinical care, research, and education to improve outcomes for the pregnant mother and for the baby she's carrying.
One area that's come up of great importance that I'm sure is center stage for the Society of Maternal Fetal Medicine is maternal mortality. What can you tell us about that from your perspective?
Unfortunately, while it's much safer to be pregnant in 2014, especially in the United States, there are still over 700 women every year in the U.S. Who die from pregnancy-related issues. So to put it in perspective, there are 4 million births in the U.S., so many women, get pregnant and give birth to babies, but still some die. And in the world, there are 287,000 women who die of pregnancy-related causes. So as a society, and really as clinicians, as doctors, just like you and I are, I think it's important to make sure that people talk about this and we decrease, these rates. In the world, obviously, there are many things that we can do, but even in the U.S., we continue to have mothers who die who probably shouldn't have died. And one of the shames that we have in the U.S. is that our data actually is not that good in terms of how many there are. In fact, the data that I just gave you is from 2009, and the CDC doesn't have more recent data. So what we actually started to do with the American College of Obstetrician and Gynecology, with us at the Society for Maternal Fetal Medicine, with the CDC, the Centers for Disease Control, is to state by state, territory by territory in the U.S., get a better handle on the few mothers who still die, to try to find out exactly why they die. Only when we have that data, we can do better reviews and work on prevention. I'll give you an example. The common causes of deaths are usually clots, thromboembolism. Hemorrhage is still a high cause. Preeclampsia is a common cause. But there's still some suicides, there's still some trauma, and we really don't have a good handle on those numbers. Some states do better than others, but in some states we really don't have an idea of how many mothers die and why they do.
And one guest that I talked to on this very topic likened the idea of the push that you're talking about to essentially trying to conduct a nationwide M&M conference to really get a better sense of identifying these cases and find out what could have been done, as you're saying, on a nationwide and perhaps even more global wide scale. But this seems like a very daunting task, doesn't it?
It's a daunting task, but one of my presidential editorial is titled, "If we don't count them, it means we don't care." And I truly believe that. In fact, I've heard a government official recently say that, there's only 700 women dying in the U.S. It's a low number. I mean, it made my blood boil, to tell you the truth. And while it's a daunting task, there are people that work in vital records, statistic offices in every state. They may be underfunded. They may not have the right instruments to collect that data. So we need to work, some of this happens in the hospital, most of them. So we need to work with residents, with fellows, with nurses, with whomever is coding this. We need to work with the vital statistics people at the state, and we need to work with the CDC. So it's a daunting task, and that's why I really love the team effort that I see growing. ACOG, SMFM, CDC. It's not going to be, you by myself or, me and you together. We really need, and that's what we've done. We're appointing people at the state level, both doctors like you and I, and the actual staff already working on this to figure out exactly their problems, because in every state it's a little bit different. For example, California and New York do a little bit better, some other states do a little bit worse. And we want to kind of emulate the states to do better to get better data.
I see. And while you're doing that, while you're undergoing that task, are you also doing anything to address perhaps guidelines, updates, or creating checklists for the clinical observation of patients who are at risk or potentially at preventable stages for some of these acute afflictions which can happen in pregnancy? And are you addressing the social determinants that come into play when we talk about maternal mortality?
Great question, yes. I'm a great believer in evidence-based medicine. And I'll tell you a little story. Obstetrics years ago got the so-called wooden spoon because we had so little evidence for what we did. That's what from the Cochrane, a big organization that kind of looks at the best research. Recently, actually, they've kind of patted us on the back because we have a lot of randomized studies, even on pregnancy causes. And so I thank all the thousands and thousands of women who have participated in these studies. At SMFM, in the last few years, now we have over 60 guidelines on pregnancy care, and in particular high-risk pregnancy care, the care of the sick mother, as I said before, or the sick baby. So at smfm.org/guidelines, but you can go to just smfm.org, you will see all of these guidelines, which are actually based on evidence. There's a lot of stuff we did for years, which unfortunately has not panned out in these randomized level 1 evidence studies. And we've been lucky to work with great experts in our field. We've been lucky that some of these have been done with ACOG as well. And those guidelines can help not only maternal mortality, obviously, but it can help also on perinatal morbidity and mortality in terms of improving the health of the baby, not just the mom.
Well, if you're just tuning in, you're listening to ReachMD, the channel for medical professionals. I'm your host, Dr. Matt Birnholz, and I'm joined by Dr. Vincenzo Berghella. He's president of the Society for Maternal Fetal Medicine and professor of OBGYN at Thomas Jefferson University School of Medicine. So, Dr. Berghella, why don't we move over to another area of passion for you and just change gears a little bit, and that's the subject of happiness with physicians. It's an incredibly important subject, but one that, in my opinion, doesn't really come up enough. Even though we hear about burnout, we hear about these other keywords, we rarely hear the term happiness being applied, and it's an area that you've really investigated. Can you tell us a little about that?
Yes, I did recently for myself a strengths survey, and my number was strengths was learner. So every time I stumble on an issue, I try to really go to the bottom of it, and happiness is something the last few years I've researched in depth. I wrote a book about it, and I actually found out there are many also randomized studies, and there's a lot of evidence published in The Lancet or New England Journal of Medicine on happiness. And there are actually 6 issues that really much are the key to be happy. The number one, and by far the most important one, is social relationships and interactions. Then there is doing what you like to do. There's having goals in life as number 3, making sure those goals have meaning. And I couldn't find a better meaning, for us OBGYNs, that, improving the health of mothers and babies around the world. Then there is the issue of working hard and being engaged in what you do. I always say, look at myself as being in flow when I'm doing something that I really like, forgetting where I am, what day it is. And happiness really on that 5th point, it's action. So that's a very important point. And the last one, it's something that you would relate to. Once you achieve something, getting the pat on the back, getting recognitions, from others. And I think that relates to a lot of what we do. You can make that to patients, for example. You relate to patients and you ask them about different options. And, doing what you like to do, it's an important thing. So listen to the patients first, letting them know the options, but letting them decide. The issue of social relationships, how important, again, it is to stop and listen to patients. Sometimes we talk so much, we don't listen to them first. So I think it's, while happiness, we think of it personal, and I think a lot of those things you could see as personal. Most of our time, or a lot of our time, is professionally at work. And if we can have strong relationships at work, if we can do what we like to do, during our day, if we pursue goals which are important to us and have meanings, and then get recognition for that after working hard, that's happiness.
That's perfectly put. And I like how you distinguish working hard from having goals. A lot of times people say, well, if I have goals, that's enough. But the idea of working hard seems intuitive, and yet people often roll those two together. They think, well, as long as I have a goal, clearly I'll work hard for the goal. It's not necessarily the case.
Not necessarily the case. And, I'm not, I don't want to sound like a workaholic or anything like that. A goal could certainly be spending time with your kids, spending time with your partner. Hobbies are a big, big key to happiness. There's lots and lots of studies on that. But the issue, for example, of giving, it's another big issue. There was a randomized study of Harvard students, I'm just remembering, and they were given a sum of money, and they were told in the next 24 hours, spend that sum of money either on yourself or on others. And then a couple of days later, they were sampled in terms of happiness. And these happiness questionnaires are actually very objective. And you can imagine the ones who spend it on others had more happiness. So this issue of giving in our profession of medicine, it's really what should be making us happy and having an harmonious life.
Makes sense to me. Let me change gears once more, because given the position that you're in, you have a front row seat to some of the more cutting edge aspects of what's occurring in OBGYN. Take us through a little bit about what's on the horizon for the field.
I'll cover two issues. One is related to genetics and prenatal diagnosis for our babies, and one is related to prematurity, which is our number one killers of babies, unfortunately, still in the U.S. and really up there in the world. In terms of prenatal diagnosis, there is something called non-invasive prenatal testing. It seems futuristic, but really it's reality now. We can actually take the mom's blood, just a regular blood draw, and find the baby's DNA while she's pregnant, even only 10 weeks or 11 weeks pregnant, early in pregnancy, and test to see if the baby has important issues such as Down syndrome or other aneuploidies. And a recent study that just came out last month by Dr. Norton, Dr. Wapner, and colleagues showed that test is not good just for high-risk women, but it's actually good for all women. The test we had before had a lot of what's called false positives results. So we were labeling a lot of women high risk. Your baby may have Down syndrome, we don't know. You may have an amniocentesis or CVS, but those tests are not completely safe. Now with these new non-invasive prenatal tests, we actually can pinpoint exactly which one have it and which ones don't. The false positive rate is like less than 1 in 1,000, extremely low, compared to 5% in the past. Mm-hmm. So that I see as a great advancement for the woman who wants to have prenatal diagnosis. Obviously, not everybody may want it, but the fact that we have a test that is safer for women, it's a big advancement.
This would be cell-free DNA-based technology?
Cell-free DNA-based technology, which again, right now it's a little expensive, but more and more insurances are covering. They're covering already for example, women over 35 years old or more. But as this study roll out, I believe that insurances will pay for everybody to have the test because it's so much more precise. And eventually, if you save invasive procedures, if you save some babies from complications they shouldn't have had, it'll probably be cost-effective as well.
I see. Do they don't render moot the other gold standard, more invasive test, do they? Do they potentially render them obsolete?
They kind of do, which is a big change in our field because actually, we make money from amniocentesis and CVSs. But if we don't need to do them, if they're a better test, I'm all for this major step forward. And eventually, and this is obviously the apple in the sky or the near future, not only be able to test for Down syndrome or other aneuploidy, but you may be able to test for the whole genome. Actually, not too recently, a couple of years ago, somebody published a study that, again, from the mother's serum, they were able to test the whole genome of the baby. Mm-hmm. Can you imagine the whole genome? So that raises ethical issues, how much you want to know. But the technology is coming soon at us, and we have to be prepared to use it in the best way to help the mother and the baby.
And I believe you also wanted to speak a little bit to preterm birth, an area of strong interest for you.
Yeah, so in the U.S., as I said before, we have 4 million births, and still about 11.5% are preterm, so almost 500,000. And in the world, actually, over 1 million babies die every year from being born too early. That's a baby dying of being born too early every 30 seconds. It's amazing, and it's a humongous amount. 10 years ago, I used to listen to talks all the time, we don't know what to do, the rates are going up. Actually, the rates in the U.S. have been going down the last 6 years. They went down 10%. And there are many reasons for this. One of them, for example, is related to the fact that there are less multiple gestations from assisted reproductive technologies, like from IVF and stimulation of the ovaries. But one of the things that I think as maternal fetal medicine specialists we've been able to do is find a much better predictive test to again predict the women who are going to deliver preterm versus the ones that will not and don't need any therapy. And cervical length screening has been such an advance. It's a good predictive test. And now there are many randomized studies that show that are actually interventions that you can implement once you find a short cervix. And the ones that I would like to highlight briefly are if you are a low-risk patient carrying a singleton gestation and you never had a prior early birth, preterm birth, you can actually have one of these transvaginal ultrasound cervical length at around 20 weeks. And if the cervix is short, vaginal progesterone seems to prevent about 45% of preterm births that would otherwise subsequently occur. And that's the majority of patients that eventually deliver preterm. And in terms of high-risk patients, so singleton with a prior preterm birth, we've seen that giving them all progesterone decreases preterm birth incidence in general. And if you also do actually a few cervical length ultrasound between 16 and 24 weeks, if you place a cerclage, that also decreases the incidence of preterm birth by about 30% and the incidence of the baby dying or being very sick, of morbidity or mortality, by about 36%. So we finally have algorithms that are evidence-based, that are both supported by the Society for Maternal Fetal Medicine and by the American College of Obstetricians and Gynecologists. And I think all of these better evidence, algorithm, guidelines, research has led to the 10% decrease in preterm birth we just talked about.
Well, with that, we've run out of time. I wish we had more time to be able to talk to you about this. We've covered an extraordinary gamut of subjects within OB/GYN and beyond, and I very much want to thank Dr. Vincenzo Berghella, President of the Society for Maternal Fetal Medicine and Professor of OB/GYN at Thomas Jefferson University School of Medicine. Again, Dr. Berghella, thanks so much for your time. It's been great.
Thank you. It's been a pleasure.
I'm Dr. Matt Birnholz, and you've been listening to ReachMD, channel for medical professionals. For access to this podcast or any others in our library, please visit reachmd.com. And thank you for listening.